You know, it is just a surprisingly frustrating reality that, according to recent survey data, about 39% of women seeking help for perimenopause symptoms
Yes.
and like 27% of those seeking help for full menopause symptoms were basically told by their GP that they would, quote, just have to learn to live with it.
Well, it is a staggering statistic. I mean, it really is. And it gets even more complicated when you look at the medical training side of things.
Right.
Because around 80% of OBGYN residents actually report feeling completely uncomfortable discussing menopause.
Wow.
So, you have this massive demographic of people going through a really profound physiological change, and the medical professionals they're turning to are, well, often just not equipped, or sometimes simply unwilling to manage it effectively.
Which means the burden of advocacy falls entirely on you, the patient.
Unfortunately, yeah.
Yeah.
Really does.
Yeah. And that is exactly what our mission is for this deep dive. We are looking at a stack of medical frameworks today, including the official NICE guidelines, that's the National Institute for Health and Care Excellence, along with some really great insights from the British Menopause Society and various patient advocacy groups.
Some really vital resources in there.
Definitely. Because the central question we are answering today is, what exact questions should you ask your doctor to ensure your menopause symptoms are actually taken seriously?
Exactly.
We're basically extracting a battle plan. We want to equip you with the specific strategies and the hard data you need to really steer that conversation in the consultation room.
Because, I mean, this is about much more than just managing a few hot flushes. This is about reclaiming your long-term health.
Absolutely.
But to take control of that conversation, you actually have to start long before you ever even sit down in the doctor's office. You need to gather your evidence.
Right. It's like preparing for a trial.
Yes, exactly like that.
Yeah. You wouldn't walk into a courtroom and just tell the judge, I feel weird.
No, they'd throw the case out.
Right. You need a case built on documented patterns. And mapping out what is happening to your body over a period of weeks or even months, that's step one.
It's crucial.
The symptom diaries, provided by groups like Bupa and Henpicked, they really emphasize tracking not just what the symptom is, but its severity on a numerical scale, like a 0 to 10 kind of thing.
That severity scale is vital. And we aren't just talking about the classic vasomotor symptoms either, like the hot flushes and night sweats.
The ones everyone always talks about?
Right. Often the symptoms that first drive people to seek help are the hidden ones. We're talking about severe brain fog, really disruptive mood swings, heart palpitations.
Oh, and the intense joint or muscle pain?
Yes. And there are actual physiological reasons for all of these seemingly unrelated issues. It isn't just random body chaos.
Well, let's get into that, because I think a lot of people feel like their body is just falling apart for no reason.
Right. Well, it all comes down to estrogen receptors. They are located all over your body, not just in your reproductive system.
Okay.
They're in your brain, your cardiovascular system, your musculoskeletal system.
Yeah.
So when your estrogen levels start fluctuating and dropping, you feel it literally everywhere.
That makes so much sense.
Like, for example, there's a condition called genitourinary syndrome of menopause, or GSM,
Okay, GSM.
because the tissues of the bladder, the pelvic floor, and the vaginal canal are just packed with estrogen receptors. A drop in estrogen causes those tissues to thin out and lose elasticity.
Which leads to things like, what, chronic urinary tract infections?
Yes, chronic UTIs, vaginal dryness, and pain during sex.
Oh, wow. And because those symptoms can be incredibly difficult or just, embarrassing to talk about with a doctor.
They go completely unmentioned.
Right.
Up to 84% of women will experience GSM at some point. But if you are actively tracking it in your diary and bringing it up, a doctor might look at a complaint of recurrent UTIs or joint pain just totally in isolation.
And they completely miss the overarching perimenopausal pattern.
Exactly. They miss the forest for the trees.
But looking at these symptom trackers from the sources, there are over 30 possible symptoms listed. I mean, from tinnitus to restless legs to sudden new allergies.
A lot.
It is. So if you only have a standard 10-minute slot with a GP and you slide this massive 30-column spreadsheet across the desk.
You risk overwhelming the doctor entirely.
Yeah. Like, how do you avoid that?
You do, which is why you must prioritize. Once you have your comprehensive list built out, you have to identify the top 3 or 4 symptoms that are having the most severe, measurable impact on your daily life, your relationships, and your work.
Oh, okay. So you really narrow it down.
You go into that room
Yeah.
and you focus relentlessly on those primary disruptors. The minor symptoms, those are just supporting evidence.
There is also a really practical logistical hack I found in the advocacy materials to deal with that 10-minute time crunch.
Oh, the double appointment.
Yes. When you call your practice to make the appointment, do not just accept the standard 10-minute slot. You can explicitly ask the receptionist for a double appointment.
It is such a simple but totally underutilized tool. I mean, you are dealing with a complex, multi-system transition here. 10 minutes is barely enough time to take your blood pressure and say hello.
Exactly. Booking a double appointment gives you the breathing room to actually go through your evidence properly.
And while you have the receptionist on the phone, you should also be asking which clinician in the practice has a special interest or specific training in women's health or menopause.
Because it doesn't have to just be a whatever random doctor is available, right?
You are looking for a Menopause Society certified practitioner, or at least someone who has done additional training in it. It doesn't necessarily have to be a GP, by the way.
Oh, really?
Yeah, many nurse practitioners and internal medicine specialists are highly knowledgeable and certified in this specific area.
Okay, so you have your data,
Yeah.
you tracked your top symptoms, you called and booked a double appointment with the right clinician.
You're prepped.
You're ready. Now you need to know the medical rule book that the doctor is actually supposed to be following. In the UK, that means understanding the nThis guidelines, specifically Guideline NG23.
The holy grail for this.
Right. This is the official framework for identifying and managing menopause. And understanding this guideline helps you clear the very first and often biggest hurdle, which is getting the actual diagnosis.
And the guideline is very, very explicit on this front. If you are over the age of 45 and otherwise healthy, menopause should be diagnosed on your symptoms alone,
Wait.
meaning no blood tests are required.
Now, I have to push back on this a little bit because, and I'm sure people listening are thinking this too, as someone who loves data and evidence, a blood test sounds like the ultimate proof.
It does sound like it.
Right. Like if I break my arm, I want an X-ray to prove it. If I am in menopause, why wouldn't I want the hard lab data to basically force the doctor to believe me?
It is completely counterintuitive, I know, because we are so conditioned to believe that lab work is the ultimate gold standard of truth.
Exactly.
But you have to understand the physiology of the perimenopause transition. Essentially, your brain and your ovaries are having a massive communication breakdown.
Okay.
Your brain sends out a hormone called FSH follicle-stimulating hormone to tell your ovaries to produce an egg and release estrogen.
But the ovaries are running out of eggs at this point.
Right, so the ovaries just don't respond. The brain senses the low estrogen and completely panics, so it pumps out even more FSH, basically screaming at the ovaries to do their job.
Sounds exhausting.
It is. And occasionally the ovaries will suddenly respond with a massive surge of estrogen,
Yeah.
and then the very next day, they drop right back down to nothing. It is a chaotic roller coaster.
Oh, I see. So if you take a blood test, you are literally just taking a snapshot of one single moment on that roller coaster.
Yes, exactly. If you happen to get your blood drawn on a Tuesday when your ovaries temporarily surged, your estrogen might look completely normal on the chart, and your FSH might look fine.
And then what?
Well, an uninformed doctor will look at that snapshot, completely ignore your debilitating symptoms, and say, well, the lab work says you aren't in menopause.
Ugh, that is so frustrating.
It really is. That's why nThis Guideline NG23 recognizes that these blood tests are highly unreliable during the transition phase. The clinical diagnosis must be based on the symptom diary you tracked.
Knowing that is incredibly empowering. I mean, it prevents you from being delayed or dismissed by a doctor who's just waiting on a misleading lab result.
Absolutely.
Are there any exceptions, though, like where you would actually want the blood test?
Yes, the main exception is age. If you are under 40, your doctor absolutely needs to run blood tests to investigate for premature ovarian insufficiency, or POI.
Okay, that makes sense.
And in some very specific cases for people between 40 and 45, checking FSH levels can be appropriate. But for the vast majority of people over 45, the symptom diary is your diagnostic tool, not the needle.
Okay, so this brings us to the actual interrogation phase. You are in the room, you have your symptom-based diagnosis, but we don't want you to just be a passive recipient of whatever prescription pad the doctor reaches for.
Right, you need to steer.
We want you in the driver's seat. What is the first major question you need to ask your doctor to ensure you are getting the right care?
The most critical question revolves around hormone replacement therapy, or HRT. You need to look at your doctor and ask, What are the pros and cons of the different forms of HRT for my specific medical situation?
And we aren't just talking about asking for hormones generically, right? You really need to know the delivery mechanisms.
Absolutely.
Because from what I'm reading in the sources, taking HRT orally, like as a pill, versus taking it transdermally, like through a patch on your skin, a gel, or a spray, that has vastly different effects on the body.
The mechanism of delivery matters immensely, particularly concerning risk factors. When you swallow an estrogen pill, it has to be absorbed through your digestive tract and then processed by your liver. This is called the first pass effect.
Right. And when the liver processes oral estrogen, it can actually trigger the production of certain clotting proteins in the blood, right?
Yes,
Which slightly increases the risk of blood clots or deep vein thrombosis.
exactly. But if you use transdermal estrogen, so a patch on your leg or a gel rubbed into your arm, the hormone gets absorbed directly into your bloodstream.
Skipping the liver entirely.
Precisely.
Yeah.
It bypasses that first pass metabolism in the liver completely. Therefore, transdermal estrogen does not carry that same increased risk of blood clots. You want to ask your doctor to explicitly explain these differences so you can make an informed choice.
That is such a key distinction. You also need to ask about combined HRT versus estrogen-only HRT, right?
Yes, and that basically comes down to whether or not you still have a uterus. Estrogen thickens the lining of the womb. If you take estrogen alone, that lining can build up unchecked, which unfortunately increases the risk of endometrial cancer.
Ah, okay.
So to protect the uterus, you have to add a progestogen to thin the lining back down. That is combined HRT. Estrogen-only HRT is generally only prescribed for individuals who have already had a hysterectomy.
Okay, here's a question that addresses a massive misconception I saw in the data. You need to ask, can I start HRT if I'm still having my periods?
Oh, the answer to that is an absolute yes, and you must push back if a doctor tells you to wait.
Because that's a common thing doctors say, right?
Extremely common.
Yeah.
It is a very persistent medical myth that you have to suffer through the entire perimenopause transition and literally wait until your periods have completely stopped for 12 full months before you are, quote unquote, allowed to have HRT.
Which is just cruel, honestly.
It is. The medical consensus is clear now. You can, and often should, start taking HRT during perimenopause while you are still menstruating to manage the symptoms as they arise.
But that leads to a crucial follow-up question you need to ask in the room. Is my HRT the same as contraception?
A definitive no. And confusing the two can lead to massive surprises.
I can imagine.
HRT is designed to top up your declining hormone levels to alleviate symptoms. The doses are not high enough, nor are they formulated to actually suppress ovulation like a birth control pill does.
Right.
Furthermore, if you start HRT while you are still having your regular periods, the HRT will often regulate your bleeding. So it helps the natural cessation of your cycle.
Oh. So you might think you've reached full menopause because the HRT is regulating things, but you could actually still be ovulating occasionally underneath it all.
Precisely. You will not know exactly when your natural fertility has actually ended. You must ask your practitioner specifically about how to manage your contraception alongside your HRT. Otherwise, you could end up with a very unexpected pregnancy in your late 40s or early 50s.
Definitely something to avoid if you're not planning for it. But what if you go in with this whole list and your doctor just doesn't want to talk about HRT at all?
It happens.
Like, what if you have a family history of breast cancer or a complex cardiovascular history, and the GP just says, hormones are too risky for you, and just shuts the conversation down?
You never, ever just accept a blanket no from a general practitioner regarding complex HRT cases.
Okay.
If you have a complicated medical history and the GP hesitates, your next immediate question is, given my complex history, I would like to be referred to a menopause specialist to discuss my options safely.
Right, because GPs are generalists.
Exactly.
Yeah.
Menopause specialists are specifically trained to navigate the nuanced risk-benefit analysis of HRT for breast cancer survivors or people with heart conditions.
This brings up a really insidious issue about what doctors do offer when they are uncomfortable prescribing hormones. I want to look at a quick scenario here.
Sure.
Say I have a burst pipe in my house, and there is cold water just flooding the floor. I call a plumber, and instead of fixing the broken pipe, the plumber just turns up the thermostat in the house so I don't feel the cold water as much.
That's a great analogy.
The pipe is still broken. So what if the doctor hears your symptoms and just hands you a prescription for an SSRI, an antidepressant?
It is an incredibly common scenario. An SSRI is a selective serotonin reuptake inhibitor. Our data shows that the main symptoms women first present to their GP with are often anxiety, depression, brain fog, and sleep problems.
So the GP hears anxiety and low mood and just reflexively reaches for the antidepressant.
Exactly. And there is a physiological link there, to be fair. Estrogen helps regulate serotonin in the brain. So when your estrogen drops during menopause, your serotonin levels get erratic, causing those exact mood swings.
Right. So the doctor thinks, I'll give you an SSRI to boost your serotonin.
Yes. And while that might take the edge off the mood changes, turning up the thermostat in your analogy, it does absolutely nothing to fix the underlying estrogen deficit.
The burst pipe.
Right. It doesn't fix the systemic issues like bone density loss, cardiovascular changes, or the genitourinary syndrome we talked about earlier.
So how do you actually challenge that SSRI prescription while you're sitting in the room?
You ask them point blank.
Yeah.
You say, are you prescribing this SSRI for clinical depression, or are you prescribing it to manage my menopausal hot flushes and mood changes?
Put them on the spot.
Yes. And if they admit they are prescribing it for the menopause symptoms, you politely reference the rulebook. The NICE guidelines explicitly state that SSRIs should not be used as a first-line treatment for vasomotor menopausal symptoms.
Oh, wow. So you literally use the official framework to redirect the conversation back to the root cause?
Exactly. You say, based on the NICE guidelines, I'd like to discuss HRT as the first-line treatment. Or if HRT is genuinely contraindicated for me, I would like to explore menopause-specific cognitive behavioral therapy.
No, wait a minute. CBT is talk therapy.
It is.
If someone is having severe physical hot flushes, like waking up totally drenched in sweat, how is a psychological therapy going to stop a purely physical sweat?
It sounds wild, but it's a fascinating mechanism.
Yeah.
Hot flushes occur because the drop in estrogen actually causes the hypothalamus, which is your brain's internal thermostat, to misfire. It suddenly thinks your body is boiling hot. So it triggers a massive fight-or-flight response in your sympathetic nervous system to dump heat. Your blood vessels dilate, your heart races, and you sweat profusely.
The brain is basically just overreacting to a totally normal temperature.
Yes, menopause narrows your thermoneutral zone. That's the temperature range where you feel comfortable. What menopause-specific CBT does is train your brain to downregulate that sympathetic nervous system response.
Really? Just through therapy?
Yes. Through specific cognitive pacing and physiological relaxation techniques, you can physically calm the central nervous system, which essentially widens your thermoneutral zone back out.
That is incredible.
The studies show CBT is highly effective as a non-hormonal treatment for reducing the frequency and the severity of hot flushes, as well as the insomnia that comes with them.
You are basically rewiring the physical stress response.
You are.
But okay, let's look at the absolute worst case scenario.
Let's hear it.
You've tracked your symptoms, you booked the double appointment, you declined the unnecessary blood tests using the NICE guidelines, you asked all the right questions about transdermal HRT and SSRIs.
You did everything right.
And the doctor is still dismissive. They still look at you and tell you it is just a normal part of aging and to deal with it. Where do you go from there?
You have to prepare yourself for the reality that tenacity is required. The patient advocacy data shows a very stark statistic here. 36% of perimenopausal women report that they visited their GP 3 times or more before being prescribed appropriate medication or help.
3 visits just to get a baseline standard of care? That is exhausting.
It is exhausting, and it requires you to actively push back against a medical professional, which, let's face it, most of us are deeply conditioned not to do.
Right, you feel like you're being difficult.
Exactly, but you have to reframe this in your mind. You are not being difficult, you are being an advocate for your own longevity.
So what's the plan?
There is a clear escalation protocol you can follow. Step 1 is simply asking for a second opinion.
Just flat out.
Yes. This is a standard built in right in the healthcare system.
Yeah.
You can literally say, I appreciate your perspective, but I would like to discuss this with another practitioner in the practice.
And if the culture of the entire practice is just unhelpful?
Then you move to step 2, demand a referral. You ask to be referred to a dedicated NHS menopause clinic, or, if you have the means to go private, you bypass the GP entirely and search the British Menopause Society, register for a certified specialist in your area.
And if you meet resistance, even getting the GP to write that initial referral.
That is when you formalize the escalation. Step 3, you write a letter directly to the practice manager.
Oh, putting it in writing.
Always. You document the timeline. You detail that your severe symptoms are significantly impacting your quality of life. You state that you are aware of the NICE guidelines and you formally request a redirection to a practitioner with a special interest in menopause.
Wow, you really have to treat it like a legal procedure.
You do. You have to internalize a key phrase from the medical literature. Once you are in menopause, you are always in postmenopause.
Right, menopause isn't a threshold you cross and then it's just over, like fighting off a flu virus.
No, it is a permanent, lifelong physiological shift. The drop in estrogen permanently alters the operating environment of your bones, your heart, and your brain. When you are fighting for this care, you are advocating for the health and mobility of the next 30 or 40 years of your life.
Okay, let's recap the battle plan we have extracted today.
Let's do it.
Your primary objective is to ask the right questions to ensure you are taken seriously. You start by tracking your top symptoms, especially those hidden ones like genitourinary changes and measuring their severity.
Right.
You book a double appointment. In the room, if you are over 45, you politely remind them that guidelines say you don't need a blood test to prove your diagnosis.
Crucial step.
You ask specific questions about the benefits of transrenal HRT versus oral pills to bypass the liver. You ask about combined versus estrogen-only therapies. If they hand you an SSRI, you ask if they are treating depression or menopause, and you redirect them back to HRT or menopause-specific CBT. And if you are still dismissed, you demand a second opinion or a specialist referral.
That toolkit gives you agency. It prevents you from being swept along by outdated medical habits, and it puts you firmly in the driver's seat of your own systemic health.
I love that. And I want to leave everyone with one final thought to mull over, really drawn from this research today.
Okay.
So today we have focused entirely on the intense negotiation required just to get basic, appropriate medical care from highly trained doctors.
Yeah.
We've talked about gathering data, quoting official guidelines, refusing to back down when dismissed. But several of these advocacy frameworks we looked at also feature extensive sections on how to talk to your manager and your HR department about menopause.
Right, because the symptoms don't stop at work.
Exactly. The brain fog and the exhaustion don't stop when you clock in. So think about this. If you have to build a rigorous legal style case and advocate this fiercely just to be heard in a medical clinic, how might you need to adapt these exact same evidence gathering and negotiation skills to change the culture and get the structural support you actually need in your own workplace?